We are truly grateful for the partnership of all of these sponsors that goes on now in the context of these events and also in other ways. So I am delighted to welcome everyone here today for this continuing discussion about connecting communities, health, and care beyond the COVID pandemic. We have been really living through quite an extraordinary experience over these past 15 months. And if we really think about the lessons that these 15 months have given us as a community, as a state, as a society, we also have to think about what we take from it into the future. I really do feel that we have to ask ourselves about, can we rise from the ashes to forge policies and practices for a Connecticut where all residents can be their healthiest, regardless of race, ethnicity, zip code, income, or immigration status. We need to forge into existence a system that equitably nurtures health. And so today we're going to explore these questions from the perspective of public health and its role in forging a state of whole health in our communities. Other dialogues have explored the perspective and roles of community health centers and will, in the future this year, explore those roles with regard to hospitals and the behavioral health system. I have the pleasure today of introducing and talking with two dynamic leaders in public health in Connecticut and nationally. To my left on the screen is Jen Muggeo, and Jen is the Deputy Director of Light Health District in New London, I believe you're located, correct? The district serves 9 communities, including New London. And to the right on my screen is Liany Arroyo, who is the director of the Department of Health and Human Services for the city of Hartford. And you both are really, we're very honored to have you. So thank you very much for being here. And I would like to remind everyone that if you haven't read their bios, we sent you their bios in our communications to you about today's event. So look for their bios in the invitation. Before we start, I want to make sure that everyone knows that this is an interactive event. And while I will be in conversation with Liany and Jen for a while, there are ways that you can submit your questions. We want to see your questions, and I would like to get to as many of them as possible. Use the Q&A function at the bottom of the screen that's to the left of the chat. Don't use the chat. It's harder for me to keep track of the chat and easier to track the questions in the Q&A. So on that note, let's start. And I know both of you have been invited to speak at different things, and people are asking you about the lessons of the experience during COVID. When we all got together a few weeks ago to plan for today, you both talked with me about the collaborations that existed in your communities that actually formed a basis, a foundation, a platform for your work on COVID. So if you could tell us a little bit of a story about those collaborations that help us understand what it took to develop them before COVID. What were they for? How did you build trust? I'm not going to, lay out all the questions. Let's just talk. Tell us about that prior work. And I think I'm going to start with, I'm not sure, with you, Jen. I'll start. Go ahead.
Thanks so much. And thanks for having me. for this conversation today. It's really my honor to share the story of our collaborations in Southeastern Connecticut, and most especially those that we've been developing through the Health Improvement Collaborative of Southeastern Connecticut, which is a multi-sector group of community stakeholders and community members who have been meeting since 2015 to collect and review data related to our community health assessments and develop our community health improvement plans, and then really take ownership and work together to implement strategies to address the prioritized health concerns identified in those plans. So
what kind of organizations form that collaborative?
So besides the health department, we have representation from the local hospital, from the federally qualified health centers who have sites in our area. We have housing organizations, social service providers, behavioral health providers. We have community-based organizations, a food justice organization, different community members, and really everyone realizing the importance of us all working together to identify those systemic barriers to health. This isn't about delivering new health education or things like that, programmatic. It's really about where can we identify those touch points that are becoming barriers for folks in our community and work together to dismantle them. And in 2019, our collaborative centered addressing racism as a public health issue. And so pre-COVID, we've been developing capacity to identify and dismantle structural racism and white supremacy really as the center of our collaborative efforts to advance community health.
So clearly those dysfunctions, those breakdowns in the system, the gaps that exist predated COVID, and certainly the disparate impacts by race and ethnicity and income predated COVID. So you already had begun. How about you, Liany? How about in Hartford? Tell us a little bit about that.
So I came to Hartford in December of 2017 after having been outside of Connecticut for many, many years, a Connecticut native, but after high school, I went to college and didn't come back. And so I stepped into a new community because I'm originally from Bridgeport, and was lucky enough to land into a community of like-minded individuals who really wanted to see Hartford progress as it related to health. And so I stepped into what at the time was known as the North Hartford Triple Lane Collaborative. It essentially was the beginning of a health collaborative here for the city. It had initially been brought together by Trinity Health of New England, who had received funding from their system office to do some work around systems change. And they had brought together all three hospitals, so our Children's Hospital, our Hartford Hospital, St. Francis Hospital, had also brought in the United Way and other funders who had an interest in this kind of work. So I came in right at the beginning, and we were learning more about each other. I was learning more about them. The health department had been a part of the effort initially, but for those that know that, the health department had been through a lot of changes, and so there wasn't necessarily a consistent effort there. So I came in and I saw it as an opportunity to learn more about these players. These are individuals who are making decisions about health, and also working together because we also formed the health working group for the North Hartford Promise Zone. Okay. So that's how our work came together around this. There was a funding opportunity for one of our major hospital systems, as well as the opportunity to serve as the health work group for the Promise Zone. And so from that perspective, there were little sort of grants that have come in to address particular issues that have come up through our community health improvement plans that all three hospitals had done, as well as the city. And so we were looking at addressing some of those issues: food insecurity, with big focus on food insecurity, having been funded by the Robert Wood Johnson Foundation, and then having had the opportunity to be funded by the state for the health enhancement communities work, really looking at childhood well-being, as well as healthy weight. But there was really a consensus around really wanting to look at childhood well-being and looking at trauma and looking at adverse childhood events. And so our work really took took place in that space with a big focus on the North End, which if you're familiar with the North End of Hartford, we have the poorest community in the state, and we also have one of the largest gaps in terms of life expectancy. And so that work really made it easy to bring and reach out to folks when COVID struck. We had developed relationships already. There was trust that had been built to seek out other grants that we had been funded for. And so working together for COVID was a pretty quick, really in many ways, sort of flipping a switch. We were able to make connections. The mayor was able to call upon people because we had all been in many ways working together already. And having developed that trust, I think really helped to be able to move things very, very quickly. And these partners have devolved into other groups that have been created as well to tackle other issues or other grants opportunities that we've had in addition to COVID.
It's very interesting because in both of your examples, the health department, if I understand correctly, in Ledgelight's case, the health department wasn't necessarily the convener, but an active participant. Am I accurate on that, Jen, or were you the convener?
I would say that in the beginning, we partnered with the local hospital to convene the group initially.
So that was your role. That was your role. You pulled together, and then in Hartford, though, it had been pulled together by another entity, right? But it was like there, and you saw it as an opportunity, Liany, to bring the Hartford Health Department into the table in a bigger way.
So absolutely, they had brought in the health department already, but I think it was timing, me being new and realizing the potential for the collaborative of helping me learn about the city very quickly, but at the same time, letting them understand where I was coming from and the ideas that I had and be able to seek that support for some of those ideas.
Yeah, and so how did you build that trust? Like what does it take to build that trust to get to the place where when COVID hit, you were able to pivot?
I guess I'll start. I'm unmuted. For us, our collaborative had an opportunity to already start working together. And what I think the biggest thing was seeing that we could work together and that people were keeping their word. And that we were being upfront with each other about opportunities that existed and who was going and working together to identify who may be better positioned for an opportunity to go for it. So I think for us, it was really about having those early experiences already, working together and really being able to see that people kept their word. And if they weren't able to keep their word because of other things that were happening, that dialogue existed. But it's really about dialogue, I felt, and being able to keep your word for the work that you were doing within the group and honoring that.
Sounds like common purpose, reliability, and trustworthiness were really important in Hartford. How about in Ledgelight's case?
Yeah, I would absolutely echo that. I think being very intentional about that was really important. In 2016, after we produced the first community health assessment and improvement plan all together, and the group said, well, we don't want this just to sit on a shelf anymore. We want really to continue to meet and propel this work forward and own our responsibility for this. We spent quite a bit of time, several meetings that were dedicated solely to talking about what were our collective values, putting those words to paper, and trust is woven through that document. And I think that it is about continually centering the importance of the relationships that we've built, and being open and the communication, just as Liany mentioned, sharing the funding opportunities that are coming up and saying who's in the best position to receive this funding for our community. It's not about our individual organizations. It's about the work we're doing for our community members that we serve, and coming through on your promises and being vulnerable, right? It's hard to hard to be vulnerable within your organization, forget about across organizations sometimes. But I think that it's so important because it contributes to the trust, and it makes it safe for other people to be vulnerable. And though relationships, the individual relationships, people represent organizations. And so our individual relationships we've been building carry forward the relationships between organizations. And it's what made it possible for me to text somebody at the FQHC or the hospital to say, how are we gonna, this is today's fire around COVID. What are we gonna do together? How are we gonna solve this problem? You know, the intentionality that went into developing those relationships was crucial in this emergency.
Talking about the importance of that foundation of trusting relationships and the individual relationships, because yes, individuals make up organizations. And I think one of the points I wanted to make is that in the case of Ledgelight, where there's 9 communities, it's a regional district, that could happen, right, is remarkable, really, because we tend to be so siloed in the ways that we work between communities in Connecticut. And so if we could take another, 45 seconds to think about what you've both described, like we've just been through a global pandemic crisis where there wasn't enough personal protective equipment, where we knew people were dying and they weren't getting into care, where we've just been, so there may be many communities in this state that didn't have that collaborative foundation to build off of, and yet there might be, we just don't know, right? So I'd like you to reflect on, like, what is the role of public health in forging that collaboration so that when the crisis as well as the opportunities that you've both described strike, you are ready, we are ready. How about you, Liany? You want to, or do you want to build on that, since you're really in a multi-town district, Jen?
I was going to defer to Jen first and then.
Sorry, Zoom awkwardness. Yes, we have all of the municipal departments that you have in the city times 9, right? So the communication can get more complex. I think that 2 things are important. Many of the organizations that serve on the collaborative do serve the region already. So, when I think about TVCCA is our largest social service provider throughout Ledgelight's jurisdiction, and in fact, for all of New London County. Our service area is the same as the primary catchment area for L&M Hospital, and we only have 1 hospital versus Liany has 3 in her service area. And also, speaking to the role of public health as convener, I think that through the years of establishing really great relationships with the people within our individual municipalities that we serve, and being that always centering the fact that we are their health department. Our director of health was the person that all of the superintendents were turning to, all of the CEOs were turning to, all of the Parks and Rec departments were turning to. And again, he was able to convene those leaders from all of our member towns, and in many cases have collective conversations with all of them, and all of them making decisions, so that even though they were implementing things at the municipal level, most of the time the things that were being implemented were the same across our member towns, because we were the convener for those conversations. So I do think that that's an important role for local health to be taking on in times of crises and beyond.
Well, that on that note, I want to actually shift us to what difference did these prior relationships make for your communities during COVID? Like, what happened during the COVID crisis that exemplifies the benefit of these prior relationships? Liany, you want to take a stab at that?
Sure. I think for us, when we got our first COVID case, we had an amazing family. The wife of the gentleman who was our first diagnosed case wanted, she reached out. She was very open with us, letting us know everything that was happening and how it happened. And when she called us and said, my son who with special needs has symptoms and I can't get him tested, and I really need to know, it allowed me to pick up a phone and call someone, first at the state, then at the hospital, to be able to say, I need this and I need this done now. It's critical. And we were able to do that because we had those relationships. And it was the same thing when we had a situation in an assisted living where the person was not going to be able to leave the assisted living facility to get tested at a drive-through without putting other individuals at risk in that vehicle with that person, where we were able to pick up the call and say, can you get a test? Can you get a kit? They'll do it and they'll deliver it back to the hospital. Those were the sorts of things that having these relationships allowed us to do. It allowed us to get meals to individuals when they needed meals. It allowed us to do many things that had not yet been set up at the time by the state, because we were able to move much more quickly. And so I think about those relationships that were developed through the collaborative, those relationships that the mayor brought into this work as well, from the work that he had done. We're in a very lucky position to work for a CEO who is very, very involved in this process, who doesn't have a problem making phone calls at whatever time to bring people together and to ask for things. And so having that sort of backup of my position, knowing that if I needed something and I wasn't getting it, I can call the mayor to make the ask. All of those things were really helpful. We were able to very quickly pivot to testing. We had pretty widespread testing in mid to late April, which hadn't been happening in other places yet. So we had gotten testing set up in April. And again, that was simply a phone call from the mayor, convening everybody, conversations with me, and doing that. So I think those were the types of things that having those relationships allowed us to do, and to do quickly. And we were able to continue to sort of pivot off of those as new challenges arose. So vaccines became the next thing, and we were able to pivot off of all of that.
Well, I'd love to, hope we have time to talk about the vaccine rollout, and maybe we can go there now in the context of Light, because I know you said that, Jen, you said that the racism as a public health crisis was something that Light and your partners identified far before COVID. And I know you all also did a lot of running interference to make sure that the vaccine reached the people that needed it most quickly. So why don't you tell us a little bit about that? And then let's shift into these positive changes that have happened. How do we go, not business as usual? But first, tell us, let's talk about the vaccine rollout in both places, because I think it's an interesting story that our participants would like to hear. Go ahead, Jen.
So, the vaccine rollout has been and continues to be fraught with challenges. And I think that this is not in response to the question you're asking right now. I think that when we are through this, and I'm saying through in quotes in response to one of the comments in the Q&A, because we're not through it, but when we look back and we really do a good examination as a state of what happened and how we can do better next time, the idea of talking about equity versus actually centering action on equity really needs to be examined. So, I'm leading with this to say as a reminder for everyone that there were some decisions about the vaccine rollout that were out of the hands of individual vaccine providers, right? We could not stray from the rules that all vaccine providers across the state had to follow, both in terms of who was eligible at what point, and who the clinics could be open to and things like that. So
that's not to say we didn't try, right, Jen?
That's right.
We sure did, mightily.
So working within the confines, we worked hard to think about how to make the vaccine as accessible as possible for the folks who were currently eligible, and really lifting up our role as the health department to be thinking about those folks who were facing more barriers than other people. So we did have vaccines being provided at mass vaccination sites hosted by the local hospitals. We did have the federally qualified health centers vaccinating. And so who did we need to be centering and designing our clinics around? And so that meant creating a new registration process that was easier for people to use, that could be used over the phone if they didn't have a computer, that was made available in Spanish. It meant holding back appointments that were only accessible for people to get by making a phone call to us or a community partner because they didn't have a computer or a strong internet connection or English language skills to navigate the website. It meant thinking about where the clinics were being hosted. And not only are those locations accessible from a transportation standpoint, is it in the middle of the neighborhood so it's walkable or on a bus line, or can we get the senior center bus to run around the city and get people there, but also from a comfort standpoint, are they buildings that feel welcoming and accessible to people, where they feel safe going to access care? Because this was a scary thing for community members to live through, and now it's a scary thing to be thinking about getting vaccinated by this group of strangers in a school gymnasium. So where really mattered. And so I'll stop rambling. Those are just some of the things that we thought about in our clinic design in the earlier phases of the vaccine rollout.
But because you were able to do that, because you were prepared for that, right? You were prepared and you were creative, I think, right?
And our partnerships, again, mattered here. Was the superintendent of schools ready to take a text message asking us to use the gym? Was the New London Senior Center bus ready to staff up on a Sunday so that they could drive people there? Were the municipal leaders ready to provide some support with traffic and signage and communications? And also meeting with our hospital and federally qualified health center on a weekly basis to make sure that as the vaccine providers, we were all communicating with each other about who we were reaching, what we were seeing, where were the gaps, so that we could collectively address them.
So Liany in Hartford, your experience on this front.
I'll piggyback a little bit off of what Jennifer said in terms of filling gaps. We are, my colleagues look at us as a larger health department. I still think we're a small health department considering all of the challenges that we face as a community and the residents that we serve who have multiple challenges that need to be addressed. But we are in a situation where we have two major hospital systems that are in our city. And then we have our third, the Children's Hospital. We have 4 federally qualified community health centers and 1 lookalike. And so we, in many ways, we're just here to fill gaps as a health department. We are here to ensure that those that have the least will have access. And that's how we positioned ourselves, right? Because we saw, saw the system that had been put in place. And if you can design a system that in many ways could have been the most inequitable system that could be designed, that's what was designed from the top down. And that's just not in Connecticut, that was across the board, because that's what we were getting. You have to use technology, you have to follow these rules. You have to follow these guidelines. And when you think about having done disparities, where we used to be disparities, now it's inequities work, for 20 years prior to the pandemic, we knew what was coming down the pipe with this. Technology was going to be a barrier. I mean, it was a barrier in March of 2020 when we pivoted to
digital divide.
We knew transportation was going to be a barrier in our city, where 30% of our community does not own a vehicle. We knew that language was going to be a barrier. So we knew that these barriers were going to exist. And so our first week out, to Jennifer's point, we try to eliminate as many of those barriers as possible. And while our first week of vaccinations, we were actually in a senior complex vaccinating, because we felt it was important to do that. So in mid-January, we went out, and that was one of the second places. Our second vaccination clinic was in a senior housing complex that has experienced over a dozen deaths. And so we purposely chose that complex. Again, because of relationships, we put out the SOS. We're here. We want to vaccinate. You know, these are the places that we're looking at based on deaths, based on age, based on population that we can reach. And we had a relationship with this particular. They knew us and immediately said, "We'll do it." And within 2 days, we were there vaccinating their residents. And so that was the sort of tact that we took. It was clear, though, very shortly thereafter, 2 weeks of vaccinating, trying to stay true to an online system, that when I walked into my department, we're in the heart of the North End, largely African-American community, that I had never seen so many Caucasian people in my lobby. And that was when I made the decision to pull out of the online system. It was a lot easier to manage an online system where people can go on and make their appointments and everything great, and they just show up. But after 2 weeks of realizing I was not vaccinating Hartford residents, aside from those that we were going out to actual clinics and doing, and which were maybe 2 a week. And so we're now 2 weeks in, and maybe done 2 or 3 clinics at the time for Hartford residents, that it was problematic that was what we were doing here in the city. And so we pulled out of the VAM system and then became a call-in center and doing phone calls. Our partnerships allowed us to then bring in our hospital systems and say, give us blocks of your appointments, because you're not vaccinating our residents either. Give us blocks of your appointments. And we started scheduling into their appointments as well. So it was that kind of work and that shifting that allowed us to move from just being what we thought was going to be the vaccinator of almost last resort, to actually being a key player and being able to vaccinate our residents. And so we've established that we've done over 10% of Hartford residents have been vaccinated, about 12% to 13% have been vaccinated by our city health department, which doesn't seem like a lot, but for a health department that has one APRN that's half-time and one full-time nurse and one nurse supervisor, we've brought in a lot of resources to be able to do that. And our partners really have a lot of work that they've done with us as well. Again, opening their scheduling systems to us when we said, look, this is our allocation and this is how many phone calls we're getting. Could we schedule into your system? And they immediately said, yes, let's figure it out. And we're able, and again, because of trust. So accessing somebody's Epic system is a leap of trust.
That's a big deal. That's a big
hospital to do, right? Those were the sorts of things that we were able to do because of those relationships. And that also helped them vaccinate more of our residents, because you're situated in our city. So we want to make sure that our residents are accessing that as well.
A couple of comments have been put into the Q&A about, one, that public health is actually not just the health department, but a collection of community organizations across the board, hospitals and community-based organizations and school districts and the mayor's office, and everybody pulling together. That public health is actually a team sport. It's not a spectator sport. And I think that's a really important point that Stephanie Palomeno makes in the Q&A, and that we're, another person, Bill Shortell, says we're still going through this. We're not done, right? We're still going through this, and who knows what's ahead of us, right? We still don't know that either. what the stories you both have shared, though, tell us that there are ways of working. It is possible to work this way on an ongoing basis. So I want to shift the conversation and the time that we have to how do we not go back to business as usual? From the public health perspective, what do you feel is needed moving forward to learn and grow from the experience that we're still going through?
I think from my perspective, there's quite a bit that's needed. We need to continue and support these collaboratives that existed prior to COVID. I think for those communities that had very active collaboratives, where that trust had been built, they were able to pivot relatively quickly to move things along. So I think there's a need to have that across the state where those opportunities exist. The other piece I would say, and I don't want to neglect this, is funding, unrestricted funding. It's really challenging to access funding to be a part of and have people sitting at a table for a collaborative. Folks have competing priorities. And if it's between going to this meeting where I may get something out of it this week or this month, but next month I might not, and I'm up against a deadline, it becomes challenging sometimes to have to make those decisions. And you don't want to make those decisions. You want to be able to be an active collaborator and part of those groups. And so I think having unrestricted funding is critical to allow. Well, it allows us to do a couple of things. Number one, it allows there to be a person whose job is to be at that table. It is their responsibility to be at that table. It's not an add-on. When we talked about the ability to pivot, I think Jennifer and her boss will probably say, yes, we were pivoting, and most of us were probably working 12 to 14 hours a day for 6, 7, 8 months. And so there wasn't a person necessarily responsible for keeping some of these things going. It fell the organization, the thinking. There's lots of work that has to go into these relationships. That follow-up, if something comes up in a meeting, that follow-up has to happen. And so having someone whose job or a part of their job is to keep these meetings going beyond this. Like for us, again, we have funding from different projects that we're working on, as well as a small amount of unrestricted funding that we're using. And we have a paid director for the collaborative who helps keep things moving. But having that is a luxury, and then having the funding to be able to pivot quickly when a crisis occurs and not have to wait for funding is also a luxury that many of these collaboratives don't have. And so I think funding is critical. Our infrastructure in public health has not been invested in. Public health is not healthcare. There was a lot of investment in the hospitals and in the healthcare system during COVID. And there's a lot of money coming through right now for public health, but it's all very much focused on COVID and not on rebuilding the infrastructure that allows me to have 3 nurses on staff who can continue to work on HIV/AIDS, who can work on STIs, who can work on overdoses, who can work on a whole host of other issues that don't get addressed because there's not funding for them. And so I think it's important that we think about, there doesn't always have to be an impact that is this measurable impact in order for there to be impact that's happening. And I think funders, federal government overall needs to rethink some of that. It's okay to say, here, health department, here's $150,000. Hire someone to do this work, or to be here, to be prepared for that next thing that we don't know what it is at the time. Or to continue to do things that are critical that didn't go away, as Jennifer has an overdose behind, that didn't go away during the pandemic. And we continue to deal with that and are now continuing to find new ways to have to deal with that as we're sort of coming out and peeking our head on the other side of the pandemic that still hasn't yet ended.
All the other problems that have existed continue to exist. And actually, a lot of the conversations that I've been involved with lately have really pointed to the mental health impacts of the pandemic and how we're really not prepared there either. There's a question that I think I'd like to pose from the chat, from the Q&A, about the tables and whether there's, in your opinion, have there been anybody missing? And in particular, I'm interested in adding to that community residents, right? Because the professionals, even though there might not be the funding, the professionals see this as part of their, responsibility. And those professionals who do that will participate in the ways that they possibly can. The residents of the community quite often aren't able to participate. So why don't you, Jen, take that? How, what's your reflection on that?
Yeah, thanks so much for that question. And it's actually where I was thinking of going. I think what Liany mentioned about funding and also our earlier conversation about trust, these are two areas where as we're thinking ahead about what's next and what was missing, funding and trust as it relates to community members, not just across our organizations. We early on in the pandemic, we were working with a team of community ambassadors who, because of a funding stream, we were able to compensate to bring their skills and professionalism and knowledge of the community as people who live here and who know people who live here to the work. And the data that they were able to help us collect and explore deepened our understanding of what had come out of our community health assessment, and also laid the groundwork for our collective response at the beginning of the pandemic, where we pulled together a survey and to get out to community members kind of a rapid response about what were the really immediate needs that we could be working on as a collaborative. And what I would really love to see us develop with some of the funding that's coming down now is kind of institutionalizing those feedback loops with community members, where we are integrating into our planning, where the municipalities are integrating into their decision making about how they're allocating some of the recovery funding that's coming. Both the ideas and priorities of community members as they exist in normal times, and then also the really heightened needs that come up in times of crisis. So that there are channels and multiple channels, right? Online surveys are great for some folks and do not feel safe for other folks. Meeting people in the park, taking phone calls in multiple languages, filling out a form. There has to be multiple touch points that are considered as valid by the institutions. And the feedback loop has to go both ways. It's not about collecting people's stories to add to our grant application.
It's about hearing what people want and need directly from them.
Get directly from them and coming back to them and showing them how we're being accountable and fulfilling our responsibilities to them. We do have community members, individual community members who participate on the collaborative, but not nearly enough because of how our society and economic systems are structured. So to Liany's point about unrestricted funding, that means we should be allowed by the federal government to spend money on food to bring people together and to compensate people for their time and pay for childcare and all of those.
So let me interrupt you there a moment, because I think if going back to normal, whatever that thing that we thought was normal was, that didn't work and that has had a continuing history of inequity and disparity, is not an option. What do you want policymakers? I mean, on this point that both of you have brought up about how to use the resources that are coming into the state, what do you want policymakers in Connecticut to take away from the examples that your respective communities have lifted up, that about how those resources should be used once we get them here in Connecticut, but also the voice that we have to convey to the federal government about what works and what doesn't, right? Because the federal government serves us too. So, you know, Liany, you want to take that one?
I'll try. I'll try and be polite. Uh, you know, when I think about policymakers, both at the state and federal level, I think for me the biggest takeaway in this that I hope that they have learned from is that equity matters and that it's not an afterthought. Um, I feel, I'll speak for myself, that equity was an afterthought in this process. That it was about being as quick as we can, which has its benefits, and there's nothing wrong with wanting to be quick, but being quick left people behind. And we're still struggling to catch up with those people right now.
Mm-hmm.
These are not working with our communities, to the gentleman's point about, you know, Hartford being under vaccinated relative to the state. It wasn't until April 1st that I could vaccinate the vast majority of my residents. Up until then, up until March 31st, until midnight that night, I only was able to vaccinate 40,000 of my 122,000 residents. So that's a much smaller proportion because of the age than my colleagues in West Hartford, than my colleagues in Bloomfield, than my colleagues in other places here in the state. It wasn't until April 1st when that number jumped to 95,000 individuals. So it more than doubled overnight. And then shortly thereafter, we had the J&J pause, which hurt across the board. And so we needed to have baked equity into this from the beginning. And I don't believe that it was, neither at the national level nor at the state level, really. I think there were intents, they wanted, that was a desire, but the things that needed to be done up front were not done. The other
if equity had, I'm sorry, if equity had been baked in from the beginning, I don't know what that noise is, but it keeps coming up. If equity had been baked in from the beginning, very quickly, how would that have been different in Hartford? What's the difference that would have made?
I would have been allowed to vaccinate anyone in my community that wanted to be vaccinated on day one. Mm-hmm. I would have been able to say, okay, I did my 75-year-olds, I've done my 65-year-olds. Now, anyone that walks through that door that's a Hartford resident, I should be able to vaccinate. Because the reality
would have been the one to decide.
Yes, that we would have had that option, that would have been allowable, versus worried about what suburb was going to say what about the fact that Hartford had access before others, or that New Haven had access, or that other individuals had access in New London, that they had access before some of your other municipalities. I think there was such a desire to have equality that we pushed equity to the side. And so we had individuals who were bringing their 65 or 75-year-old grandparents or parents, and I couldn't vaccinate them. Like, I couldn't vaccinate them because I wasn't allowed to. And so I think those were sorts of the things that for us were very challenging, because we knew that once things opened up, I was going to see a lot more 65-year-olds, because the 45-year-old mom is not going to come out with the 65-year-old mom to get the 65-year-old mom vaccinated if they've been quarantining this whole time. And we saw that on April 1st, we saw families, multi-generations coming in. Great grandma, mom, right? We saw a handful of those through our first clinic in early April, because they were waiting so that they can come together rather than having multiple people leaving the house at different times. And so
that would have been understood with an equity eye as well, in terms of how families take care of one another.
Absolutely.
I think there's a question about like how much more is needed in both in our state, right? I mean, and if we if we had done it a different way, we would be further along. So there are still targeted populations that don't have sufficient vaccination rates, and that is a result, although those communities, those populations are tagged or labeled as hesitant, for example, or resistant. The reality is that they also haven't had the opportunity. I want to go one other question, and I'm trying to make my way also through the Q&A. There's still food insecurity. There's still housing insecurity. What do policymakers need to understand going forward about the experience of working on COVID, transferring to these other determinants of health?
I think that this is a pivotal moment for us and for policymakers in terms of truth telling and acknowledging the reality of our systems, which are, for too many in our community, systems of oppression. And being real about the policy, the deliberate decisions that are made that place people at risk. And whether that's at risk of food insecurity or exacerbated outcomes to a disease like COVID or heart disease or overdose. We have made deliberate decisions that created these inequities. And if we try to pretend that we haven't, we are doing great harm. This is an opportunity with the federal dollars that are coming down to listen to the community members and center their needs. They are the subject matter experts. We are here to serve them and create opportunities for their lives to be better. And I'm afraid that the decisions about how dollars are spent are going to be made by people who have always made the decisions, right? So I really hope that we can create a new way of being.
Thank you very much for that. We're almost near the end. I want to just say in the next couple of minutes, shift us to the need for unrestricted operating support, right, is something that federal and state government tend not to be reliable sources for. We know that. The philanthropic community in Connecticut also the philanthropic community was challenged to step forward in a different way and to also develop mechanisms for rapid response. And the philanthropic community has learned a great deal about how it sort of ties organizations up in knots too along the way. So that I think that one of the outcomes has been more unrestricted funding, faster, less bureaucratic application processes. And so as we go forward, the philanthropic community in Connecticut is also needing to look at what we learned from and are learning from our current experience to what is needed, especially when all of us are really very committed to systems change. That we know the problem is not the people, the problem is the system, right? We know that. And so can you both reflect on the partnerships that are needed with the philanthropic community? Real quick though, because we only have like 4 minutes. Sorry.
I wanted to piggyback a little bit off what Jennifer said and tie it into this answer. I think Jennifer hit a lot of great points. I think we have an opportunity, not only in Connecticut, but nationally, to use these funds to be transformational. And am frightened that we're not. I'm frightened that we're falling into the same trap of using these funds in the same way we've used them before rather than being transformational. And so I hope that, you know, I've seen different cities address this challenge issue of the ARA funding, and I know Hartford has put together, I think, what is a solid plan, and I hope to see it be implemented in other places, but we have an opportunity to be transformational, and I hope we don't miss it. That's, I think, something for policymakers to know. When I think about the philanthropic community, I will say, I have never had such a good relationship with foundations in my 20+ career in public health and seeking funding from foundations and working with foundations as I had now. I would say that foundations really stepped out and said, we're just gonna give money where it's needed, and we're gonna listen to the people that are giving that have that connection. And so I wanna say thank you for that. And I think we need to do more of that. I think we need to have foundations sort of ask those questions of what are you missing, rather than this is our strategic plan and this is what we're going to fund, but what are you missing? And that was a question that I was asked by several foundations, and I was able to say, this is what I'm missing. And having the flexibility to then, when all this other funding came through the pipe, to talk to the foundation and say, I'm not going to use up all your money right now because I got this other money that has a deadline, and I'm able to now scaffold this money to make things go longer, has been a blessing for the foundations that we've been able to work with that have funded us. And so I think taking what they've seen and understanding that we could be, as health departments, good stewards of funding, can work with community partners very well, because we do it on a regular basis. And those are critical lessons for foundations to keep for the future, because there are other issues that we could use that flexibility on to allow us to better address some things that are happening in our community.
Thank you. Thank you.
I would echo that and thank the foundations who have provided funding for us. And just to the point you made, Frances, about everyone being committed to systems change, it's a both and, right? And so we are all committed to systems change. That is the work we're doing. And also we are serving our community members in the systems as they exist now. So I'm really grateful, for example, to the Connecticut Health Foundation providing funding for a community health worker to help our community members navigate the systems that we're living in now, while we also work collectively for that systems change.
I think it is both and. I think that's really, really important, because public policy plays out in people's lives every day. And while you're trying to change public policy, which is a long and protracted and very messy process, people's lives, like those stories that you told, Liany, about the individuals, they're happening, and they're not thinking about the system. They're thinking about their reality. So philanthropy can do that. Philanthropy can play in both sandboxes. And I thank Tiffany for putting that question on the table in the Q&A and leading us into that discussion. So I think we've covered most of what was in the Q&A. We've covered the waterfront in this conversation. I want to thank you both for the work that you do, the leadership that you exercise, and the influence that you are having. And thank you for taking time from your extremely busy day to be here with us for an hour. I want to make sure that everybody knows that we have this webinar recorded, and we're going to put it on our website and share it through social media, and we hope that it will be shared forward, because really these are ideas that we've got to think about. And beyond thinking, talking and thinking, we have to actually, as you said earlier, come together and say, okay, now how are we moving forward? How are we going to use these new resources? How are we not going to go back to business as usual? So I thank you all, our audience, our sponsors, the Universal team, who we couldn't do this without, and follow us and follow your organizations on Twitter, Facebook, and Instagram, and stay tuned. Thanks again. Take care. Bye.